Assalamu alaikum. So this is a case of left-sided non-functioning kidney due to mid-ureteric or distal ureteric stricture. So I have mobilized the colon. I have identified the ureter, which is very much dilated up to the pelvic ileal system. And now this is the gonadal vein. This is the vascular anatomy. You can see the renal vein, the gonadal vein. So we are looking for the renal artery first here. Dissecting the renal vein medial to the insertion of the gonadal vein can be a dangerous maneuver, especially when it is not required. That is in case of a non-functioning kidney. However, in case of renal tumors, especially the transitional cell carcinoma of the renal pelvis, dissection medial to the gonadal vein may be required as oncological requirement. So that's why after dissecting the gonadal vein, identifying the adrenal vein, showing it to the trainees, I swiftly move towards the renal artery lateral to the gonadal vein. Here you can see some lymphatic tissue surrounding the artery, which upon touching can lead to a bit of ooze due to small vessels running along the lymphatics. So for that, using a small gauze piece is a good gadget to clean the space immediately. So we have identified the renal artery, which is just behind the renal vein. However, it is so much engulfed by the lymphatic vessels that it's difficult to define its course. However, using our ligashore and then using our 10 millimeter right angle forceps, we can dissect the renal artery. Here the window is created behind the renal artery. So one clip on the renal artery, and then we will check whether it is completely occluded. So as you can see, the renal vein is beautifully disengorged, I can say. We can check the flow of blood in the vein if there is another artery. However, the vein is not distending, so we are deciding to clip it. This is the ground rule, to apply one clip on the renal artery, then applying the multiple clips on the renal vein and dividing it between the clips, and then completing the dissection of the pedicle by applying another clip on the artery distal to the proximal to the previously applied clips. So another window is created just to prevent the retrograde flow of blood from the artery. So the clip is applied, and then the artery is divided and the kidney is mobilized. So we have skipped the steps of kidney mobilization here, and we swiftly come to the dealing of the distal ureter. Upon dissection of the distal ureter, I tried to locate the exact location of the ureteric obstruction. However, it was I realized that it was not safe, so I had to clip the ureter, but the diameter was so much so that clip could not be applied completely. So I just opened up the ureter so that the urine in the distal portion of the ureter is aspirated, and then I used suction inside it so that it is empty, and then I suture ligated it. The purpose of removing or suction of the urine from the distal part of the ureter is that this part of the ureter may at times lead to infection, because the urine is static between the ligature and the stricture, and this can lead to abscess formation. sepsis and everything. So that's why I emptied the ureter distally, and then we cut the ligature, and then we divide the ureter and remove the specimen. Thank you very much for watching.